Hypogonadism in females means the ovaries do not make enough sex hormones, especially estrogen. Think of the ovaries as a factory that should produce a steady supply of a product hormone. In hypogonadism, the factory runs low on output, which can affect growth, menstrual cycles, and bone health. Common causes include genetic problems, for example Turner syndrome, autoimmune attacks where the body mistakenly harms its own ovaries, damage from chemotherapy, radiation, or pelvic surgery, hormonal problems in the brain, pituitary, or hypothalamus that tell the ovaries to work, early menopause, premature ovarian failure. The brain sends signals GnRH to LH/FSH to the ovaries to tell them to make estrogen. In hypogonadism, either the signal is weak, central cause, or the ovary cannot respond, primary cause. Imagine a phone call. If the call never connects, the message never gets across. If the receiver line is broken, the message cannot be heard. The result is low estrogen and sometimes high or low FSH/LH, depending on the level of the problem. Female hypogonadism is relatively uncommon but important. About 1% of women under 40 experience premature ovarian failure. The risk rises with certain genetic conditions, exposure to chemotherapy, or autoimmune diseases. It can affect any ethnicity, but some groups, for example those with Turner syndrome, have higher rates. Typical signs include irregular or absent periods, amenorrhea, hot flashes, night sweats like early menopause, vaginal dryness, pain during sex, low libido, mood swings or depression, decreased bone density, easily broken bones, difficulty getting pregnant. Imagine checking a calendar. If many months are blank, that's a clue. Doctors start with a medical history and physical exam, then order blood tests. Serum estradiol, low. FSH and LH, high in primary, low normal in central. Thyroid and prolactin levels to rule out other problems. Genetic tests if Turner syndrome is suspected. Ultrasound may be used to look at ovarian size. A simple flowchart helps guide the steps. Two main types. Primary ovarian hypogonadism, the ovaries themselves are damaged. FSH and LH are usually high. Central hypothalamic and pituitary hypogonadism, the brain signal is weak. FSH and LH are low or normal. Some classify by age of onset, premature, less than 40 years, versus usual menopause age. Treatment aims to replace missing hormones and address the cause. Hormone replacement therapy, HRT, with estrogen, often combined with a small amount of progesterone if the uterus is present, helps restore menstrual cycles, bone health, and mood. If a pituitary problem is found, medications like GnRH analogs or pulsatile GnRH therapy may be used. Lifestyle changes, adequate calcium, vitamin D, weight-bearing exercise, and smoking cessation. Fertility options, ovulation-inducing drugs, or assisted reproductive technologies if ovarian reserve allows. Because many causes are not preventable, genetics focus is on reducing risk where possible. Limit exposure to pelvic radiation and toxic chemotherapy when alternatives exist. Protect ovaries during surgery. Use ovarian-sparing techniques. Manage autoimmune diseases early. Maintain a healthy weight and avoid smoking, which can hasten ovarian aging. With proper hormone replacement, most women lead normal, active lives. Bone density usually improves, and symptoms like hot flashes lessen. If untreated, risks include osteoporosis, heart disease, and infertility. Prognosis depends on cause. Central forms often have better recovery potential than primary ovarian failure. Use of anti-Mullerian hormone AMH testing to better estimate remaining egg supply. Development of tissue-engineered ovarian grafts and stem cell approaches that may one day restore natural hormone production. Newer, low-dose estrogen patches that mimic the body's natural rhythm, reducing side effects. Studies on the role of vitamin D and lifestyle interventions in slowing ovarian decline.